Thanks everybody for being here and joining us today. So I'll start by introducing myself, as Marion said. Where's my clicker? So I am Dr. Emma Clare. I am here as a very proud member of both the End of Life Doula International Research Group and End of Life Doula UK. At the minute, I'm one of two directors of our UK organisation. I'm also a researcher attached to the University of Derby. And today I'm going to talk to you about integrating end-of-life doulas into the national health system. And I've done that sneaky thing that people sometimes do when they create a title for a presentation, where I've sort of deliberately made it a bit controversial. And then hopefully I will talk through and try and iron that out as we go through, because I'm very aware that some people might see this title and feel quite strongly that that isn't something that we want to do at all. So, as everybody else has had, I'm going to speak to you for about 30 minutes, relying on Marion for the time check, thank you, and then do a Q&A. So I'm going to introduce you to two collaborative projects we have going on in the UK between End of Life to the UK and NHS trusts. We have two pilot projects running, so I'm going to talk to you about how they came about, what were the background conversations, what really enabled those projects to happen, what barriers we came up against, because there were quite a few and continue to be. And I will finish by sharing what I think are some key ingredients about what we've learned so far from these projects. So the first project I would like to introduce you to is our original pilot project. So this is in Leeds and surrounding area, so in the north of England. Support through this project is available free of charge on the NHS, and it is to anybody with a GP with a Leeds postcode. So that does stretch into some areas of Bradford and over towards York as well, which is where I'm based. So this commission gave us £50,000, and it was to fund roughly 1,500 hours of end-of-life doula support. We did not, I hope I don't need to say this, make any profit from this project. All of the money received went into doula support. We had a team of around, and still do, a team of around 10 doulas, and we received referrals from healthcare professionals. Even though we were open to self-referrals directly from people, I think we only have received 2 ever. So the flow of information and people contacting us for support really is from healthcare professionals, and around 95% of the referrals were all from what is called the Health Case Management Service. So they are an NHS team whose job it is to do community assessments around designating fast track status for people in the community. So for international people joining, that means that it very quickly frees up funding for people to be able to access support at the end of life. So to date, we've had over 250 referrals, supported over 140 people, and we have an independent evaluation going on with the Open University, which we felt was really important with this being an initial pilot project. We want to really show that we're doing an unbiased evaluation of this, so we've asked the Open University to do this independently. They published a report at the Halfway Project last July, and that is available open access online if you're interested. The next project I want to introduce you to is a more recent one. So we were commissioned towards the end of last year to offer support again via the NHS in 2 southwest boroughs of London, so Kingston and Richmond. And this project began in December 2023. I forgot to say the Leeds one began in May 2022. This one was for £30,000 of funding, and then we received another £6,000, which was redirected from another project, which for whatever reason wasn't able to go ahead in the end. So we have a team of 12 doulas working on this project, and this is a mix of self-referrals directly from people at the end of life and their families who are looking for support, but we also do receive a large number of our referrals from the hospital discharge teams, mainly at Kingston Hospital, but from Richmond as well as district nursing teams and Princess Alice Hospice, which is a local hospice. So this one, with it being a newer project, we've received around 30 referrals, supported 19 people, and our service evaluation, which is going to be in-house in this case, is being led by Guy, who is here today. Thank you. So that's an overview of the 2 projects. So now I will move into speaking to you about what these involve. Now, this might be off-putting in itself, but when I first spoke to our members in particular and said that these are projects we were going to have running, we did understandably have a number of questions about, this is great, can we set something like this up in our own area? And I I'm quite keen to caution about how much work went into these behind the scenes, not just in a blowing our own trumpet kind of way. But you can see on this slide that these were the basic steps really that were needed to even get these projects started. So in both cases, understandably, we had to have some kind of contract in place, and this was much more formal in the Leeds project. We had a memorandum of understanding in South West London, which was much shorter. Both projects required us to put together a referral criteria for who the service is suitable for, so that healthcare professionals knew when to consider end-of-life doula support. That isn't something we had previously. Both projects required a huge amount of work in terms of data protection. So obviously we're dealing with very confidential information about the people we are supporting. And there's also the flow of information from NHS Trust to an external organisation like ourselves, which took a lot of working out. But we were helped massively. I know on this slide it looks like there was more work in the Leeds project, when actually that wasn't true, because we were helped hugely in the Leeds project by a local hospice, St Gemma's Hospice, who gave us an NHS email address via their organisation. And this kind of fast-tracked us really, because it meant that we automatically came under them in terms of data protection. So that saved us a huge amount of work, which we did have to do for the South West London project, which was much longer. It also meant we could access some mandatory training via the hospice. That was really simple 10-minute online training for data security and protection. The next thing that differed quite a lot was the amount of time that was required from us as an organisation to report to the NHS Trust. So Leeds, I'm not biased, there was pros and cons to both projects, but we're very much sort of, here is the money, here are the key basic things we need you to do in terms of quality and patient safety. Other than that, please go away and get on with the work and just let us know how you're getting on, which worked really well. I only needed to have 10, 15-minute meetings a month, directly one-to-one with the commissioner. So we were only talking about our project. If there was nothing new to say, we didn't have to spend any more time. And we obviously just sent them a brief report of our spend each month. This was a massive difference with the South West London project. So we were commissioned there in tandem with two other pilot projects, different ways of doing community end-of-life care. And it meant that our monthly meetings had to be reporting alongside all these other services. So that was instantly, 1-2 hour long meetings where the discussion wasn't specifically about end-of-life doulas. It was about other services that were interesting, but not related to what we were doing. And both of these projects, unfortunately, for those in the UK, will be aware of the context that we're all working in terms of NHS funding and cuts. And both projects have been heavily affected by restructures. Some of the trusts we're working with have been asked to save huge percentages in terms of staffing costs. So it has meant there's been lots of turnover in terms of our contact within the trust. So we form a relationship, we explain what a doula does, which we all know can take a little while. And then it turns out that they're leaving the position and we have to build that relationship again, which has been a challenge. So I've thrown a pause slide in here to say, should we even be doing this? Which I think is a very valid question. I know I agree with Marion, we should be asking these questions. Just two thoughts I wanted to share, and then my thoughts, there's no right or wrong about them. So the first is to really emphasize the pilot nature of these projects. We are just finding out if it works. We're finding out if it works for us as doulas. We're finding out if it works for the people we're supporting. And then thirdly, I suppose, for the NHS Trust and healthcare professionals, we want it to work for them, but we obviously are prioritising the people who we're supporting and our members as well. But I would also ask us to think about, often as end-of-life doulas, the people that can benefit most from our support are people who don't have anybody to advocate for them. They don't have friends and family to do that. And they are often the people who can get really stuck in these existing systems. They're people that might end up in hospital without being discharged home when they really want to die at home. They're people who might have to go in a care home when that isn't really where they want to be at the end of their life. So I think if we're instantly saying, no, we don't want to do this, we need to ask ourselves, are we doing that to benefit ourselves or the people that need the support? And maybe the answer is both, but it's certainly a question we need to ask at least. So on that note, I want to just talk to you about holding the line, which is a phrase that I think some people in the UK are probably sick of hearing me say over and over again. But it's the best way I can sum up what we've had to do to protect our way of working on these projects, which is one of our absolute aims. We don't want to lose what makes end-of-life doula work unique, which there's a number of different ways, but certainly the flexibility and how we are able to adapt our support when we're alongside somebody as their needs change, as their health condition progresses. We don't want to lose any of that. We also don't want to be put in a small, narrow remit box. So here are some things that we did compromise on and some things that we definitely didn't. So as I mentioned before, we put in place a referral criteria. This isn't something we generally had nationally. The way we work nationally is that people will have an initial conversation with us and then we will explain what a doula could offer them, or we might say, do you know what, it sounds like another service would be more suitable for you. In this case, as I say, for healthcare professionals to be able to refer to us, they really needed a bit of a list to instantly say, okay, this is a service we need to consider or not. So we deliberately kept that really open. It was basically that people had to be expected to be in the last 12 months of life. Of course, we never know for sure, but that was a guide. And we also had some exclusion criteria, which was around people with very complex mental health conditions requiring psychiatric support, which is something that we didn't have the knowledge of how to support alongside those services with. But we emphasised all the way through, please have a conversation with us if you're not sure, because we don't want to exclude anybody that would benefit. We also agreed to have the NHS email address, which, as I say, was actually a benefit for us in terms of the setup. And we did agree to include certain evaluation measures which were quantitative, so numerical. That isn't a way we would usually work. We all are very familiar with the importance of stories, which is how we would usually share the work that we do. But there were some things that the NHS Trust were particularly interested in, which we were interested in too. For example, does end-of-life doula support increase the chances that somebody dies in their preferred place? Are they more likely to have a good quality advanced planning document? And are they less likely to be admitted to hospital in the last few weeks of life? So we are collecting numerical data about those aspects. What we did not compromise on, all of our members in the UK are self-employed. They can decide when they work, they can decide who they work with, essentially. They can decide how they work as long as it's within our code of practice. And we did not want to lose that. So we said very early on to the NHS Trust, is it okay, this is how we work. If that doesn't work for you, this isn't something we can continue the conversation about. We were asked some questions about, how many people can a doula see in a week? And we really didn't want to get sucked into that way of evaluating our project. We are about quality support, not the quantity of people we can support at one time. And we said, look, this is going to be a small service compared to other services. We are going to support a smaller number of people. Those people are going to receive a lot more hours of support than other NHS services. And that really is the point of our work. And for those of you who are mentors of our members of our organisation, you know that we have a strict in a good way rule about mentoring. We really believe that when we're practicing as a doula, we should have a mentor who's dedicated support for ourselves. And we built that into these projects and said that that also is not something we will compromise on. So what enabled these collaborations? There's quite a lot on this slide, which I guess is a good thing, because there was a lot of help we received from other services. There were things that the doulas working on the project did to enable this to continue. So the first one, this is probably going to sound a bit biased, but was the existence of End of Life Doula UK, having a central organisation with credibility. Both of these projects came about because we were approached by NHS services. I think that, you could say it could happen, but I think that was much more likely because they had an organisation to go to. And they felt confident that we had relevant policies to evidence safe working. For example, we have safeguarding procedures in place. We also had belief and support from the commissioners. Now, I'll come on to talk about barriers in a second, and this differed quite significantly between the projects because in Leeds, one of the commissioning team heard about life doulas, really believed in our ethos. They approached us and they were the person I met with each month. So I was sort of always talking to our ally within that service. The difference in the South West London project was that the commission actually came from a GP who had heard about us and they put the funding application in for us. But then the reporting and the liaising was passed over to somebody on the commissioning team who, as many people didn't know what an end-of-life doula does, even if they did, they weren't entirely convinced that it was a good idea. So we were coming up against barriers each month where we were trying to evidence the benefits of what we were doing. And I don't think there was any kind of ill intent, but there definitely wasn't the same support and space where I could go and say, this isn't working, can we try and work this out together? It was much more, it felt more pressured, to be honest. And it also required people in the NHS Trust, so other services referring to us, and the commissioners themselves to be open to trying these new ways of working. Both of the funding pots for these projects came from what's called innovation funds. So I guess they were already earmarked for new kinds of pilot projects like ours, but it definitely required some positive risk taking. And again, it's not a criticism, but for those of us who've worked in the NHS, I have myself, there it can be a very risk averse culture. And so it really required a lot of trust from them to say, we're going to try this and it might not work, but we'll take learning from it, which was certainly our attitude. We also received a lot of feedback from other services, which I am absolutely convinced was one of the reasons that we kept both of these projects going beyond the initial few months. We heard very early on, I guess it's kind of sad in a way as well, how stretched these other services were, but we received written feedback from particularly that community team, assessment team I mentioned at the beginning, that we were taking a lot of pressure off their service. They described us as an invaluable service and felt that they would be quite stuck without us if we were to disappear. I think another thing that really helped, and this is definitely credit to the doulas working on the project, is demonstrating our ability to adapt. So again, not quite a sad thing to report, I suppose, but in Leeds, we just saw over and over again that other services around us, third sector services, NHS services, were being decommissioned, were losing their funding. A number of the hospices lost their volunteer programmes while we were working there. And we were pulled into those filling the gaps that Anessa talked about in ways that we hadn't really envisioned. So one of those, and again, it was entirely the individual doula's decision whether this was something they offered or not, was we were approached to say, one of the services that we've lost was a service that helped people to move from home to a care home or home to a hospice. And they were left with quite a stark decision of getting a company to do a house clearance, which had no personalisation, or pay for the care home and their home, which obviously was not practical for most people. So a couple of our doulas in these situations partnered up with people from the community assessment team. They hired a van, they helped somebody to sort through their things, and they helped them move, which isn't something we would usually put on our end-of-life doula leaflets, but it certainly is something that made a big difference in this case. So that's definitely an example of our doulas on these teams going above and beyond and really demonstrating those services and stories, as I mentioned. So what got in the way? Again, there was quite a few things here. So I've sort of alluded to this before, getting pulled into these meetings and these reporting structures where the same reporting is required from us as NHS services, which just doesn't work for our service. As I say, we really need to be sharing case studies and stories and having the statistics as a sort of nice add-on rather than the other way around, and those being the main thing that we're doing. So we really held the line, as I said, and didn't get pulled into that process. The next thing, and just to explain for our international attendees, is that NHS funding runs on a March to March calendar. Both these pots of money became available towards the very end of that year, essentially, because there was leftover money from the year before. So in both cases, we were granted the funding in sort of November, December time and asked the question, can you spend this money before March? Absolutely not. We have a very small team. All of these doulas are doing this alongside other work. So in both cases, we were under a little bit of pressure thinking that, okay, this might just have to end in March. We'll do what we can in 3 months' time and take what learning we can. But luckily, in both cases, we were unable to continue into the next year, largely due to the feedback that I just mentioned. Barriers from people acting as our link into the NHS. So as I've sort of already mentioned this, there was people who weren't involved in the commissioning process, didn't know what we did, who had some misconceptions about what we do as end-of-life doulas, as we know can be the case, and we need to myth bust. So having to also battle through those processes in the meetings definitely hindered us as well. I'm sure, unfortunately, many of us are familiar with some services just not wanting to collaborate with us. That thankfully, as time went on, has seemed to change. I think initially we had some difficulty collaborating with some of the local hospices, which we know can sometimes happen. But as people started to see this, I guess, essentially as a temporary NHS service, we did start to receive referrals from those other services as well. And then finally, and a bit on Anetta's point earlier, which I really agree with about volunteering, we obviously cannot expect the doulas working on these teams to drop their other sources of work. You know, this is a temporary pilot. It would be a real privilege for people to be able to do that. So individual doula availability was an issue, but no fault of their own. So we were working alongside a doula team who were often having to do this out of hours around another job, which also brought its own challenges too. So what have we learned? It is possible. Again, going back to my questioning slide, that doesn't mean we should do it necessarily, but it's good to know that maybe there are ways of ironing out all these issues that we've encountered, and we've definitely taken a huge amount of learning from it. I mentioned the halfway report last July, and there will be a full report coming out October, November time this year at the end of the Leeds project. But it takes, I hope I've shown, it takes significant time to go through these various steps. So all of that list I mentioned earlier, then for professionals to know that we exist, that we're here, we're offering support. Huge amount of work was put in by the local end-of-life doulas in terms of publicising this to services, going and speaking at team meetings, telling people what we do, answering questions, and then repeating that 3-6 months down the line when the staff team had unfortunately changed. And then once they do know we exist, and they know what we do they trust us? Do they trust us to be able to refer their patients to us? Here in the UK, if somebody is dying at home, the GP has ultimate responsibility for the person's care. So I completely understand that they need to trust they're referring to a safe service. So in both cases, it probably took 6 to 9 months to even start getting a flow of referrals, which again, evidences why it is no use saying, let's pilot this for 3 months, because it's not even got halfway off the ground by that point. The difference of having somebody on the inside championing you can make all the difference. I guess we don't need to say this maybe as end-of-life doulas, but relationships are so key to what we do, not just the people we're supporting, but our allies in these services. Without those people, these projects would definitely not have happened. We wouldn't have been approached. If we had been approached, I suspect that we wouldn't have been enabled to continue the projects beyond those 3 months. And that could have left a real bad taste in terms of, oh yeah, we tried that end-of-life doula project for 3 months and it didn't work. Well, no wonder it didn't work because of what we've seen. So thankfully, we've been able to carry on in both cases. I would say don't underestimate the challenges of relying on a self-employed team. So I myself was and am coordinating the teams for both of these projects. But that doesn't mean that doulas should not be self-employed. I completely maintain that should be the case, but I think we have to acknowledge that that is just as many ways that we work an anomaly, and is something we need to think about how just as much how can we support them as well as how can we coordinate those challenges both ways for sure. I'm sure if the members of the team were here talking to you today, they would say that they had difficulties to overcome as well in terms of how they were coordinated by us as a service as well. And evaluation, one of the things which I haven't had time to include here about feedback we've received from people that have had end-of-life doula support on these projects is that people were so much more likely to provide feedback direct to the doula, which is something that I hadn't anticipated. So we initially set up, and we still do have running, an anonymous survey created by the Open University, which I do think is a good idea to collect anonymous feedback, particularly if there are issues. But people said, well, do you know what? Actually, I'd rather just write directly to the doula and say, this is my experience. So I think in future and for the South West London project, we're doing a combination of asking for direct feedback as well as the anonymous survey as well. So this is only from 2 projects. I'm sure if we did a third one, the learning would be very different from there as well. But here are some key ingredients that I'm suggesting just from what we've learned so far. So again, I really think having a community of practice, a central organisation, however that looks, is really key, both to being able to coordinate these teams of doulas, to support them crucially with mentoring, having the credibility, and also a central pot to receive the funding. You know, it wouldn't be possible for the NHS to have commissioned individuals and transferred this money to an individual doula. So it's worked slightly different on both projects, with Leeds a bit in the spirit of, as I said, them letting us get on with the work. They gave us the funding and then just allowed us to spend it and report back. With South West London project, we invoice them each month, which is a different system, but still works. Having a strong ally in the commissioning team can make all of the difference. I do a special shout out to Catherine Millington-Sanders, who has been the GP who got this commission in South West London. And we just found out last week that we are able to extend this into 2 other boroughs of London as well, both still in the South West, so neighbouring boroughs, thanks to word spreading in those GP teams. The importance of looking at doula availability and responsiveness. We do not want to get into the system that we unfortunately know works in a lot of NHS services where there is a burnout culture. We don't want to be overly reliant on the doula teams that we have, but we do still need people to be responsive. And that's all about, to use a therapist annoying quote that I always do, about expectations and communication on all parts, telling the people we are providing support to what we can offer, what we can't offer, but also asking doulas to be upfront with us in terms of how many hours they can give to the project. Outreach and ongoing connection with other services. A huge amount of work went into, as I say, going to the local teams and speaking to them and answering questions. They had many, many questions. They had many myths about doulas, which it was really important for us to go and myth bust. Knowing when to compromise and when to hold the line, as I said before, and the importance of including feedback, including stories in our evaluation. I know we're going to hear stories about people who've received doula support today from other speakers, so I haven't gone into that in my presentation.